and pass it off to Dr. Pearson.
Good afternoon. Thank you all for attending. Today we're going to talk about the urinary bladder. This is very different than the gallbladder. The two are not connected at all. Urinary bladder problems, what we're going to talk about, they primarily affect women. Men get prostate problems, but not nearly as frequently do they get bladder problems. But some of this will apply to men as well. As Jason said, I'm John Pearson. I'm a urologist here at Community Memorial Hospital. We do a complete range of urologic services here. Some of the bigger operations we don't do here, but we do pretty much everything else. It's very common for people to get problems with their urinary bladder as they age. It's nothing to be embarrassed about. It is very common, and your doctor is there to help you with it. So if you have concerns or questions about bladder emptying or bladder control, please discuss it with your physician or mid-level, and if they think it's appropriate, they'll get you referred to me. This is a fairly common problem. We expect you to be able to control your bladder. We're going to talk about how to diagnose the problem, how to differentiate the different types of problems, the different approaches to the problem, and then we'll take questions at the end. This is a very common problem. 1 in 6 adults has problems with their bladder control. It's more common than vision problems or diabetes. There's an association between problems with bladder control and hip fractures. So if you're having a problem, it's worth discussing before it causes other problems. If you're going to the bathroom too frequently, if you feel like you don't have time to get to the bathroom in time when you get the urge, if you know where every bathroom and every store you go to is, if you have to be careful how much you drink before you go out, if you have to wear pads, these things are common, but they're not normal. It's not normal to lose your bladder control as you get older. There's a very big difference between a problem that's common and a problem that's normal, and you don't have to live with it. I see commercials for incontinence pads on television, and they talk about how you can control your problem with a pad. A pad is not how you control the problem. Those commercials ought to be taken off the air. If you have a problem with your bladder control and you need pads, you need to see your doctor. There are two kinds of nerves that goes to your bladder. One tells your bladder to relax and fill. And as it fills, you should not have the urge to go until it gets to full. And then at that point, you should get the sensation that you need to go to the bathroom and have time to get there in time. There is a reflex center in the spinal cord. As your bladder fills, the reflex center gets the message that your bladder is full. When you're an infant, the reflex just sends a signal automatically back to your bladder and tells it to empty. But once we get 2 or 3 years old, we learn that urinating as soon as you get the urge is not appropriate. and you learn to control that reflex center. You develop a pathway between your brain and that reflex center that tells it to hold the urine until you get in the bathroom and can empty. What you eat can influence how your bladder works. How to drink, primarily caffeinated drinks, occasionally spicy foods, can irritate your bladder and make you have to go more frequently and more urgently. If you're having bladder control problems, that's one of the easy things you can do, is to watch what you eat or drink that affects it and eliminate those things. There's a certain type of incontinence we're going to talk about later that is influenced by your pelvic floor, and how that occurs and how to deal with it. We try and differentiate your bladder problem into one of three groups. Number two, urinary retention means that you're not emptying completely when you go, or you can't empty at all. This can be caused by some diseases. Spinal cord injuries especially can cause urinary retention, but some other neurological diseases can cause it. People who have jobs where they can't go to the bathroom when they need to, like nurses and teachers, they gradually stretch their bladders as they get older, and the bladder loses its ability to function. And so we see retention in some occupation groups. The other two problems are just the opposite. Rather than retaining urine, you lose your bladder control. This is divided into two very different groups called stress incontinence and overactive bladder, or also called urogynecology. Stress incontinence is incontinence that occurs with activity. It can happen when you cough or sneeze or laugh, lift things, bend over. Excuse me. It is caused by your bladder falling down, essentially your pelvic floor getting overstretched, which causes your bladder to fall down. And we'll talk about how that occurs and how that's corrected in a little bit. Overactive bladder or urgent incontinence is usually caused by a nerve disease or related to aging. It is leakage that happens when you have to go and just can't get there in time. It also can be without incontinence. You can have an overactive bladder that just makes you go more frequently, but and you feel like you have to go, but you're able to get there in time, and you don't leak, but you're just going too often, especially if it's happening at night and disrupting your sleep. Stress incontinence is a leakage, as I mentioned, that occurs with activity. As we get older, our pelvic floor gets stretched out, especially in women. Three primary causes are aging, overweight, and carrying children. These things cause the bladder floor to stretch. The bladder sits on the floor of the pelvis. As the pelvic floor stretches and falls down, the bladder falls down with it. The tube coming out of the bladder is called the urethra. Basically, it's just a circular muscle, and when it contracts, it closes the urethra so your urine stays in the bladder. When you cough or laugh, that pressure increases the pressure in your bladder. It should also increase the pressure, the closure pressure in your urethra, so that when you cough, the urethral pressure increases as the bladder pressure increases and the urine doesn't leak out. But when the bladder falls down, the urethra gets pulled open and it cannot close tight enough to give you control when you cough or sneeze or laugh anymore. In order to correct that, you have to put the bladder back up where it belongs. That allows the urethra to close tight again and get your bladder control back. There have been multiple procedures developed to treat this. Slings and or one of the methods that does that. That's usually put in through the vagina. But there have been problems with that eroding or getting infected, and a lot of people have stopped doing slings. The other approach is with an operation from above, where you resuspend the bladder using a layer of tissue underneath it to put it back up where it belongs and allow the urethra to close tight and give you your control again. Urinary retention we talked about already, where you can't get your control. There are ways to deal with this. You can have an indwelling catheter, but that can cause urinary infections. Eventually can cause damage to your kidneys. You can catheterize yourself intermittently, 3, 4, 5 times a day to get the urine out. That can be inconvenient, but it works very well for some people. There's also a device called interStim, which is also called sacral neuromodulation, that helps restore bladder function in a lot of people. An overactive bladder, as we talked about, is the disease that causes urgency and frequency, inability to get to the bathroom in time when you have to go, needing to wear pads to control your leakage, and we'll get to the details about that more in a minute. First step is to determine whether your primary cause of your incontinence is urgency or stress. We do that primarily by your history, trying to determine whether your leakage is more caused by activity or by urgency. There are tests called urodynamics, where we can measure the bladder pressure as it fills and see if you have overactivity in your bladder. That helps us diagnose it. If we determine that you have stress incontinence, then we look at surgical options. There aren't any medicines that help with stress incontinence. If your incontinence is urge related, then we look at lifestyle changes first. Can we help this by changing what you eat or drink? Will exercise of your pelvic floor with Kegel exercises help? Will biofeedback help with your leakage? So that would be the first approach to overactive symptoms or incontinence. There are multiple medications on the market. When I first started in neurology, there weren't any medications for this, and women were just kind of stuck with it. But now we've developed 2 types of medications. The first medications were called anticholinergics. They help quiet the bladder muscle so that the bladder symptoms are improved. These medications do have side effects. They can cause dry mouth and constipation, which is a frequent complication, sorry. And in some people, they're so severe that they can't tolerate the medications. There's a new class of medications called beta-3 adrenergic agonists that calm the bladder muscle without all these side effects. This medication is very effective and has almost no side effects. The only problem is a lot of insurance won't pay for it or only pay part of it, and it can be very expensive. So the use of that is limited still because of insurance constraints. If you don't get the kind of relief you want from bladder retraining or diet or oral medications, Then we have other options. InterStim or sacral neuromodulation is one. Tibial percutaneous stimulation will help some people, and BOTOX is another choice. BOTOX is a medication, you may have heard of it. People get it put in their face to try and make themselves look better, and it relaxes muscle. It's injected into the bladder muscle through a scope, and it can relax your bladder muscle and get rid of your urgency and frequency and urgent continence. Unfortunately, it only lasts 3 to 4 months and has to be redone in order for it to work. Some people also, it works too well and they can't urinate and have to have a catheter for a week or two after it's injected. But in a few people, they get good results with this. But again, it has to be redone every 3 or 4 months. Percutaneous tibial neuromodulation is a very effective method for some people. It requires in-office where they stimulate the tibial nerve. Sometimes it's done with little tiny needles, like and sometimes it's done with this device. But in either case, some people get very good results with this, and it's totally non-invasive. Sacral neuromodulation is a newer method for this. As I said earlier, there are 2 nerves going to the bladder. One tells it to relax and one tells it to contract. People with overactive bladders, frequently the cause is that the nerve telling it to contract is overactive and causing the urgency and frequency. The nerve telling it to relax and hold more basically has gone to sleep. And so by putting a tiny wire down to that nerve that tells it to relax, we wake it up and tell the bladder to relax. And it gets rid of the urgency and frequency, and frequently improves the incontinence by 80 to 100%. It's a simple procedure. It takes 15 or 20 minutes to put in. It doesn't involve your spinal cord, and it can be a life changer for some people. Basically, if you failed other treatments, we would do a test to see if this is going to help you. Put this wire in, leave it for 3 or 4 days, keep track of how often you're going and how much your leakage is, and compare it to what it was beforehand. And if it looks like it's going to help you, then we put a permanent implant in. This is similar to a pacemaker. It's the same company that makes pacemakers for your heart. And basically, it's just a pacemaker for your bladder to give you your control back. It's very safe and very effective. Most of the people that use it are very satisfied with it and use it long term. So we've got all these options for you. You don't need to put up with being incontinent or going to the bathroom too frequently. We can improve the circumstances of your life and make you be able to live again.
All right. If anyone has any questions, I do not see any questions thus far in the chat box, but at this time, if you do have a question, you can, if you wish to type that in there, or if you wish to unmute and go ahead and ask your question, I'll give a moment for that. You must have done a good job, Dr. Pearson.
Overwhelmed them with too much information.
No. All right. We have a question here. What procedure do you recommend for bladder issues with coughing and sneezing?
If the incontinence is purely stress related or primarily stress We will frequently try medications first, just to see if calming down the bladder will help. But if that doesn't work, then we look at your bladder and see if it's fallen down. If there's evidence that your pelvic floor is relaxed and your bladder is falling down in your vagina or coming out of your vagina, then we go in through the lower abdomen with an incision. You'll be put to sleep, of course, for this. There's a layer of tissue under the bladder that's very strong. We put sutures in that on both sides and sew them up into the ligaments in the groin to resuspend your bladder back up where it belongs and allow your urethra to close tight enough to give you your control back. This is usually requires at least an overnight stay in the hospital, but it usually takes less than an hour to do.
All right, another question we have is, how do you go about getting, I guess, getting tested or getting a test arranged?
Well, you would come in and discuss it with me first, and if it looks like something that we might consider surgery on, or if it's something that there's a question of whether the primary problem is stress or incontinence, we would look at your bladder and see if it's fallen down, look in the bladder to see if there's some irritation to it, like a stone or tumor, and then we'd go from there depending on what we find. That procedure is done in the office. It takes about 2 minutes, and it's about as uncomfortable as a pap smear.
Okay, at this time, does anyone else have any further questions? If you choose to type a question, go ahead and continue to do so. But one thing I failed to mention earlier, we always like to ask how you heard about this program. So if you can, and the chat box is available to you, if you could just give us a heads up, whether, newspaper, Facebook, how you learned of this program that we had. But we're also still taking questions at this time as well. As people are typing this, Dr. Pearson, we received another question. If an implant is advised, is it outpatient?
Yes. The test is done usually in the office. You don't even have to go to the operating room. It's just done under local anesthesia. If we then decide to do a permanent implant, you'd have a little sedation and local anesthesia and go home the same day. The permanent implantation usually takes 30 to 45 minutes. Well, I want to thank you all for attending. I appreciate the opportunity to discuss this with you. And if you have any further questions, I'll be happy to see you in the office. Thank you.
Thank you all for your time today.